Thanks so much, and thank you all so much for a really interesting morning, and really looking forward to the next part of our morning to move on to this panel. My name is John. My pronouns are he or they. I'm an assistant professor in nursing and health systems at University College Dublin, but University of Galway is my alma mater, so I'm really delighted to be back here. This building didn't exist. The student residences weren't as fancy when I was here. My work is on kind of the intersections of social justice and healthcare. So I'm really delighted to be chairing a panel of some wonderful speakers who I've gotten to speak to around their work in this space as well. So it's and looking at kind of the legal context, which is and the socio-legal context, which is always really important for me as a healthcare provider and healthcare academic to be conscious of. So we have three papers in this panel. We have Nem, who is going to join us online. So I'm just kind of looking around to see when that is going to happen. So we will have three speakers, and we will, like the last panel, take our questions at the end. So if people want to make note or take note of questions throughout, and people will be able to ask their question from an individual panelist or to the panel. Oh, Nem is there. Hello, Nem. Nice to meet you. So our first panelist for this morning is, let me just get my my sheet open. So it's Nem Carnes, who is co-director of Disabled Women in Ireland. So the National Disabled Persons Organisation representing women, girls, non-binary people and gender non-conforming people, and was appointed to the National Autism Innovation Strategy Oversight and Advisory Group. Nem's a co-founder of NeuroPride Ireland, which is a voluntary cross-neurodivergency community organisation and DPO, as well as providing policy consultation and advocacy on gender and LGBTQIA+ equality and disability justice and how those areas intersect. So Nem themselves is autistic and otherwise neurodivergent, and we're really looking forward to your paper, Nem. So you have 20 minutes and I'm sure you'll be fine. I'm not going to worry too much about time.
Thanks so much. I'm not an academic, and I'm not a healthcare provider, and I'm not a lawyer. So my paper will be a bit more just kind of broad. Well, it's not even a paper, my rant. So I'm really honoured to be invited to participate in this summer school and to be speaking on a panel with such experts and amazing advocates. I really wish I could be there in person, if I'm honest, but it wasn't to be. So first of all, I just wanted to say I really welcome and was really kind of pleased to see the wording of the title of this. I do think it's important that we're talking about a right to health and not just access to healthcare. It's much more, and it kind of allows us to look at health as a human right, and also to have that more contextual look rather than narrowly focusing on physical structures or problems within just the healthcare system, but to view people as individuals in a society and how their various identities and experiences intersect with social structures. So I'm just going to give a very brief whistle-stop overview, not in depth, not exhaustive, of some of the ways in which the pervasive gender biases and structural ableism, in conjunction with accessibility barriers, hinder disabled people's access to healthcare and their fulfilling of their right to health. I'd like to take a moment to recognise that, as I said, that the right to health is also kind of an international standard, and that Ireland states that it aims to uphold the WHO standard of health as a state of complete physical, mental and social well-being, and not merely the absence of disease and infirmity. So it's a good aim, and one I do not believe we are fulfilling. Although I won't be speaking on it today, I feel it's also important to highlight that under international human rights mechanisms, gender-based violence is also understood as a public health issue, and it should be part of the conversation going forward. Right to health also gives us room to examine the role that socioeconomic factors, geographic factors, and additional marginalisation, such as racialisation, play in health inequity, and to challenge the pervasive narrative that for disabled people, it's enough that we survive and we shouldn't expect to thrive. People of marginalised communities of all kinds are significantly more likely to be disabled. And in Ireland, 1 in every 2 disabled people live in deprivation. And about approximately half of us experience barriers in trying to access public transport, which is why I can't be with you today. So these all intersect, and like good to keep in mind is the context in which inequity of access and inequity of representation play out. You're talking about people who are already marginalized and who generally do not have the social capital or the financial means to overcome barriers in ways that people with more of that kind of capital may be able to do so. Um, I'm also just going to mention, as a non-binary person, that I will be talking about men and women a lot, but that's only where I'm trying to reflect research and data doesn't exist for any other genders. So it's not an attempt to be exclusionary, it's an attempt to not go beyond the information I was able to access. Most of us are likely aware that there's widespread disparities in quality of care and health outcomes on gender lines. It's well documented that men are more likely to be believed when reporting pain and be offered more effective pain management, experience less delay in accessing it. Across a whole range of serious conditions, women are much more likely, sometimes to the extent of twice, 3 times, 4 times as likely to be dismissed or misdiagnosed when seeking an initial exploration or diagnosis than men are. And that can result in years of delay in accessing appropriate healthcare, which also has long-term impacts on overall health. For non-emergency serious conditions, gender marginalized people frequently wait for years or even decades longer for correct diagnoses. For one example, the EU average for an EDS diagnosis is 4 years for men, but 16 years for women. And even in urgent care, gender bias is in full force, with women 50% more likely to be misdiagnosed with a heart attack. And although cardiovascular disease is equally common across all genders, women are more have much higher fatality due to gender bias. We know that medical misogyny shapes our lives and health in ways big and small, from being told we're imagining symptoms at the doctor's office. I've honestly lost track of the number of female presenting friends of mine who go in for, physical health appointment with a physical health practitioner and to be asked, do they have a boyfriend? Are they fighting with their boyfriend? Are they worried that they won't be able to get a boyfriend? Um, and it might sound ridiculous if you haven't experienced it, but it is really common. Um, sorry. Uh, Basic diagnostic screening is also very problematic. We view these tools as objective, but like the kind of conversations you might be familiar with the development of AI, we need really to examine the information and data that went into creating the systems and the screening and the processes that we have now. The vast majority of screening and diagnostic processes were uh, built on data of only men and generally only white cis men. So these perpetuate ongoing inequities along gender lines, along racial lines, along all sorts of different ways. Uh, and you'll also see that even today, with this knowledge, with this being much more in the consciousness, that funding for issues or conditions or circumstances that primarily or do not affect cis men, such as endometriosis or fibromyalgia, receive proportionately much less funding, much less clinical trials, which again means that there's much less option choice for people who are experiencing those conditions, and a much greater impact on their health overall, their ability to participate in work, in education, in social life, and also on mental health. Untreated and especially non believed health issues has a hugely detrimental effect on people's mental health and on their self esteem and self trust. Um, it is sometimes it can be to the level of gaslighting if you're experiencing very real, very physical symptoms and keep being told you're imagining it, it's all in your head, it's all in your head. It does also leave people, when they have their sense of reality, questioned on a systemic level, more vulnerable to other forms of self-doubt and manipulation. Although we're now currently recognizing gender bias, it's still largely taboo to admit that ableism also permeates the medical system, and that the implicit and explicit biases of people who work in the field can cause harm daily. Disabled bodies and minds are often blamed for the harm they experience. How many people incorrectly comforted themselves during COVID that it only really affected people with underlying conditions, so the deaths weren't as tragic as they would otherwise be. The UK's use of quality of life assessments during COVID, again viewed as an objective medical tool, but in reality is just a way for largely able-bodied people to make assumptions about the inherent value of disabled lives. Greatly contributed to the fact that 66% of COVID deaths in the UK were of disabled people. This percentage was significantly lower in countries that took a different approach, and countries where disabled people successfully campaigned against quality of life assessments as a triage tool. Deeply embedded biases about disabled people and their supposed blanket vulnerability themselves often obscure and distract us from the results of ableist prejudice writ large. When we see unequal or disrespectful treatment, we feel more comfortable ascribing it to one bad apple or one person having a bad day. When we see stark health inequalities, lower life expectancies, and excess death for disabled people, our knee-jerk reaction is to assume these disparities must be caused by disability and to look no further. As the World Health Organization acknowledged following years of research, the wide-ranging inequities in health outcomes experienced by disabled people are unjust and largely cannot be explained in terms of the person's underlying health condition or impairment. Lack of equal access to health hinders the realization of other fundamental rights, such as employment, education, and exclusion from community life and society. It is an urgent human rights issue for the disabled community. Gender prejudices and inequalities permeate disabled gender minorities' experience of health and healthcare, exacerbating pre-existing inequities. Due in no small part to society's rampant infantilization and desexualization of disabled women, they're much more likely, less likely, to be offered reproductive healthcare options, as you probably discussed this morning, and given less choice in maternity and postnatal support. And they also report experiencing less respect, autonomy, and dignity in healthcare than non-disabled women. Disabled women are also report higher rates of sexual violence, and 68% of all maternal deaths in Ireland between 2013 and 15 were those of disabled people or people with a pre-existing condition. The dismissal and disbelief that women in general face when seeking diagnosis or treatment are also greatly magnified and compounded for disabled people who are perceived female. Healthcare professionals and public attitude surveys repeatedly show that disabled people are at high risk of being othered, dehumanized, and not viewed as credible or knowledgeable by non-disabled people, including health professionals. And widely held gender biases surrounding or interacting with impairment add further complications. The perceived fragility and infantilization of women with intellectual, cognitive, and or developmental disabilities makes them particularly vulnerable to non-consensual treatment, being denied information necessary for them to make informed choices, abuse by healthcare staff, and having their decisions disregarded in favour of those of their friends, their family or support staff. Although these experiences are shared to a degree by women in other impairment categories. Disabled women who marry are at greater risk of having their legal capacity called into question or being denied assisted decision-making rights, including in making medical decisions. Disproportionately high rates of sexual and other abuse of disabled women in healthcare settings adds to medical trauma experienced by so many disabled women due to accumulated negative experiences. And even approved treatment can be highly traumatizing when it's insensitive of the gendered aspect. Disabled women in inpatient psychiatric and long-term facilities are restrained more frequently than men, and the not uncommon experience for disabled women of being forced to be fully or partially undressed in front of multiple staff, or having their bodily autonomy and dignity infringed upon in other ways, can be more frightening, vulnerable, and traumatizing due to gendered social context and experiences. Gendered expectations in social and verbal communication also increase disabled women's likelihood of being deemed histrionic, uncooperative, or less credible, with staff perceptions of patients' expressions and emotive actions, such as crying, being given undue weight in assessing the credibility of a female-led patient's distress. Reliance on these type of secondary cues, especially in combination with the gendered expectations they're entangled with, disadvantages many non-speaking people, people with chronic pain conditions, deaf people, and others. Neurotypical people have been repeatedly shown to struggle with reading and understanding neurodivergent people's body language and expression, and to underestimate our pain and distress based on these faulty interpretations. I believe it's no coincidence that autistic people are more than 3 times as likely to die after attending emergency care as non-autistic patients are, often after being turned away. Given that the vast majority of autistic women are not formally diagnosed, and research has found there are no significant differences in healthcare experience and adverse outcomes between formally diagnosed and self-identified autistic people, it's time we remove gendered and ableist expectations from healthcare entirely if we want to ensure equal right to health for everyone. Disabled women in Sorry, I do apologise. Although menstruation can have a massive impact on conditions as diverse as ADHD, chronic pain, and fatigue conditions and brittle bones, to name but a few, it is almost never accounted for in treatments and supports, and is very rarely communicated even to patients who menstruate. There is this strange unconscious bias that being disabled somehow overshadows all other identities and experiences, and erases all biological and gender differences between disabled individuals. Real or perceived gender is also a massive indicator for inequality of experience with other psychosocial disabilities and who are otherwise neurodivergent. For example, although under current practices, males with an intellectual disability are approximately 4 times more likely to be identified as autistic, rising to 10 times without an intellectual disability, and 16 times more likely to be identified as ADHD, trials of universal screening and outpatient mental health services identified 68% of the women attending as being ADHD, autistic, or both, the majority of whom were previously undiagnosed or incorrectly diagnosed. In fact, gender and racial discrepancies in diagnoses disappeared when the universal screening approach was used, rather than traditional reliance on clinical referrals, highlighting the scale individual biases can play in correct identification and support for disabled individuals. With no public pathway to adult autism diagnosis in Ireland, many autistic people marginalised by gender and or ethnicity are never able to access formal diagnosis and are unlikely to secure reasonable accommodations in work, education, or to be able to access appropriate health services and supports. Autistic and ADHD cis women and trans people are more likely to be overlooked for decades and remain unsupported, or, which is sometimes worse, misdiagnosed, with something more in line with gender prejudices. The lack of appropriate support greatly contributes to autistic and ADHD women's massively increased risk of experiencing institutionalization, homelessness, addiction, intimate partner violence, as well as drastically lowering life expectancy to 39 years for autistic women who don't have an intellectual disability. They also experience much poorer mental health outcomes, with autistic women who aren't intellectually disabled being 13 times more likely to die by suicide than non-autistic women, more than twice as likely than autistic men. Neurodivergent people and those with intellectual disabilities or psychosocial disabilities also experience significant discrimination in accessing gender-affirming care, particularly trans people. In reality, gender-affirming care as a whole is more frequently accessed by cisgender people than by trans people, but only trans people have to access it through a separate healthcare system. In contrast with international best practice, Ireland still uses a medicalised, pathologised approach to trans healthcare. And despite calls for reform in legislative review, non-binary people still don't have legal recognition of their gender in Ireland. Trans people wishing to access gender-affirming services must prove that they experience sufficient gender dysphoria to meet this DSM criteria. They're being diagnosed with a psychiatric disorder or disability to qualify for gender-affirming services. However, if they are deemed too mentally unwell or too disabled, they may be refused access to care. There is a growing push to legislate to deny or restrict access to trans healthcare on the basis of disability, mirroring a growing number of laws internationally, which deny gender affirming care to people with intellectual disabilities, depression, and sometimes other mental health conditions, as well as autistic and ADHD people. This is unacceptable discrimination on its own merits, but the scale of the attack becomes clear when you know that approximately 40% of trans people are disabled and nearly a quarter of the trans community are autistic. Such discriminatory laws, while obviously rooted in transphobia, are justified by appealing to ableist ideas that disabled people in these the capacity to make their own healthcare decisions, and set a dangerous process for the denial of healthcare choices in other areas, setting a new precedent in Irish law, allowing for unequal access to human rights on the basis of disability. Alongside barriers and biases, disabled communities are to accessibility barriers in any detail, but I just would like to kind of throw out there what I believe aspects that need to be considered when we're discussing services. The, the most obvious one that people usually start and stop is also needs to include sensory accessibility. My connection very professionally crashed. It's probably given me a hint to wrap up. So, just to finish my little bit on accessibility, as well as physical accessibility, there's informational accessibility that includes the right to give informed consent and to communicate in one's most preferred or comfortable medium. And then there's acceptability, which is usually left out of the conversation entirely. Is the service of similar quality and type as that available to non-disabled people? And can disabled people access it as independently and autonomously as non-disabled people without there being an assumption that family members or other personal support will facilitate access? While a basic checklist approach to accessibility is for the most part fairly gender neutral and ineffective, meaningful accessibility as a means to progress equal right to health needs to be gender informed. I'm not, as I said, I'm not going to go into any kind of the various and multitudinal accessibility barriers that exist in the healthcare system, but I'd be happy to, if anyone wants to ask any questions about it later. But I'd just like to kind of pose a question instead. It's like, if access is technically possible, but is out of reach for the majority of a particular social group, can the state truly claim it is upholding its duty to ensure equality of access? I've already mentioned the figures on poverty, that approximately half of disabled people can't access public transport reliably, which includes taxis, and that much more likely to be socially excluded and have a smaller support network. But I'd also kind of want to just put out there, in case it hasn't come up so far, rarely considered, 67% of disabled women are mothers and 45% of family carers are disabled or have a long-term condition. The full context and reality of our lives is often overlooked when it comes to all aspects of our lives, but including right to healthcare, including the fact that a child in hospital may very well have a disabled parent who needs access, and many other ways of interacting. And also, disabled people should be our parents, our carers, our healthcare professionals themselves, and need to be more recognised, more included, and more supported. Um, there's and also to put kind of, just before I wrap up, the kind of the social context that all of us in Ireland, and I imagine in many, if not most countries internationally at this point, have kind of experienced that there's an increasing expectation that appropriate and timely healthcare needs to be sought privately. And there's also coupled with the long-standing assumptions that caregivers are able people and all disabled people have an able-bodied person available on hand to compensate or overcome accessibility issues or exclusion issues in health. Accessibility is still an afterthought or tick box exercise, and ignoring disabled people interacting with healthcare systems in all the ways, as providers, as users, as consultants, as parents, as family members, restricts our right to health, participate in healthcare to an equal degree, which has a long-term impacts and long-reaching impacts on our right to health. Underlying all these expressions of accessibility, differential treatment, and poorer outcomes is ableism. It is difficult for us as a society to admit that ableism exists as a structural issue. makes most people uncomfortable to accept their systemic discrimination against people we tend to describe as the most vulnerable. But the greatest trick the devil ever pulled was convincing the world he didn't exist. And until we can all confront the reality of marginalized people's experiences and the biases and social norms we've all absorbed, ableism in healthcare will continue to exist. It's essential that accessibility barriers be removed in mainstream provision, and not only to minimize delays and maximize dignity in accessing health, but also because a significant proportion of disabled adults, particularly women and trans people, do not have access to diagnosis or formal recognition for physical impairment, psychosocial disability, chronic conditions, neurodivergency, and more. Absence of diagnosis does not equal absence of need. And where there is unmet need, there are unfulfilled rights. So thank you very much for listening to me today, and for inviting me here. And I would more than welcome any questions you may have, but I won't be offended if you don't have any.
Thank you so much, Nem. Really valuable kind of insights into the intersectional nature of many different experiences of health. And I really welcome your starting off with talking about a right to health rather than health care, because I think we need to be more aspirational. And really that question on acceptability and accessibility, like it's not accessible if it's not acceptable. And I think that's really valuable. And I'm looking forward to some discussion later. So next we have Fiona. Fiona Anderson is sitting beside me. Fiona's been an advocate and activist for over 30 years, has a BA in sociology. I have to remember the title of it. Sociology. My microphone. I'm the one who's supposed to be telling other people that their microphone isn't close. So Fiona has a BA in sociology, political and legal science, and also a master's in comparative disability law and public administration, and has held a number of roles, including Disability Advisory Committee of the Irish Human Rights and Equality Commission, representing psychosocial and mental health disabilities and disabilities across the board, and is also on the Mental Health Commission Stakeholder Forum for 2024. Fiona is a country leader with the Global Mental Health Peer Network, and her interest and what she'll speak about today is around the intersections of medical and mental health law, discrimination, legal capacity, advanced to access to treatment, and in particular today looking at psychosocial disability and access to health, including reproductive health and gender affirming health. So thank you so much, Fiona, for being here.
Good morning. As you know, I'm Fiona Anderson, and before I start, I just want to remember a close friend of mine, Dr. Fiona Morrissey, who cannot be here today because unfortunately she passed away in November 2023. So Fiona and I became close confidants in recent years in our advocacy and also collaborating together to try and make differences for people with psychosocial and mental health disabilities. I was born in Dublin in January 1965, and I'm the youngest of 6 children. We immigrated to Australia in 1967, where I grew up in a suburb of Melbourne, before returning to live in Ireland in June 1982. I lived in a small village in a hamlet called Pulsamus in North Mayo. And I say in jest, I lived with an uncle and 2 aunts, and I say in jest how they took on a 17-year-old brat from Melbourne because they'd never married before and looked after me. I ended up going to an all-Irish speaking language school to do my leaving certificate, and I chose that deliberately because of the bullying that I underwent in Melbourne. I then moved to Knock in County Mayo after I did my leaving certificate, having successfully passed my exams. It was December 1988 when I experienced my first mood swing episode, which I associate with my PCOS and my endometriosis, not the diagnosis of bipolar affective disorder. Because I noticed when my menses started that my estrogen level decreased, and it causes mood swings similar to bipolar affective disorder. But it was easy to give me that label because it went on historical family background. And I wasn't treated as an individual, and I was put into a box. From the beginning, I actually did request them to do a hormonal profile at the age of 24. Okay, thank you. Okay, is that better? Better for your arm. So I was getting concerned about that. I requested them to do a hormonal profile test, and they refused to do it. And I was wondering, and it baffles me, what skin was it off their nose to have assisted me and to save me from a lot of unnecessary trauma, treatments, and all that kind of thing, and vicarious trauma from what I was seeing in the psychiatric system. I spent a period of 6 months in hospital in July 1994 when my PCOS kicked in and my estrogen levels dropped again. Again, this was ignored. It was actually 35 years of age and 39 when I was diagnosed with PCOS and endometriosis, having become associated with the mental health services in 1989. I had ECT, it did nothing for me. It was inappropriate for me, and I was started on lithium treatment in 1991. Unfortunately, that treatment didn't suit me. I've actually ended up with chronic kidney disease from it, and my function is currently about 21%. And dialysis is just looming around the corner when I hit 20%. Just recently, I was with my endocrinologist, which was 2 weeks ago today. And because my kidneys are so bad, she cannot give me any more treatments for my PCOS because they'll make my kidneys worse. They will kill me, or it will cause me a heart attack. So if I'm a bit deflated, I apologize. And a bit emotional, but that's when your mortality is put before you, it's not very easy. So to move away from that, what I want to talk to you about is trying to access healthcare when you have a mental health diagnosis. And if you notice, I interchange between psychosocial disability and mental health disability, mainly because psychosocial disability can have a negative connotation attached to it with the word psycho and the way people use it. The difficulty is in medical services to look beyond the psychosocial disability and see the medical needs of people with psychosocial and mental health disabilities. Like Tim was saying there about accessing healthcare. Well, with a mental health diagnosis, there's 4 suppositions that I've come across through my consultations in medical services. 1, it's a figment of the imagination. 2, it's a reflection of the mental health diagnosis. 3, it is psychosomatic or stress-induced. And 4, diagnostic overshadowing, which is an overemphasis is placed on the mental health diagnosis, which masks and blurs serious underlying comorbidities. This practice tends to delay in the diagnosis of comorbidities such as obesity, diabetes, and CVD, or cardiovascular disease, which may be linked to the use of psychotropic medications. A startling figure I'm going to give you is psychosocial disabilities have their life expectancy reduced by 20 to 25 years for what are foreseeable, preventable, and treatable comorbidities which may be linked to psychotropic medications like Zyprexa. Zyprexa is an antipsychotic and it has several drawbacks. It may add up to 1/3 in body weight as a metabolism and may lead to obesity, diabetes, and CVD. It can also aggravate diabetes and smoking affects its efficacy. There are various medications that actually impact on a person. A medication called Champix, prescribed to people to give up smoking, and its first major side effect is mood swings. These mood swings could happen to anyone using Champix, but especially so in those already susceptible to mood swings, and should be prescribed with caution to those with mood swing disorders. Lyrica, an epileptic drug, and may be used for pain relief, but its first major side effect is mood swings, confusion, and behavioural changes, and is a newer form of Neurontin, an epileptic medication to treat certain types of seizures, but also used for pain relief. Tegretol, an anticonvulsant medication, and may be used as a mood stabilizer. Do not use it if you're going to become pregnant because it can harm the fetus and the mother and seizures and that kind of thing. There's tritase, which is an ACE inhibitor, and that interacts with lithium, and it leads to lithium toxicity, which leads to renal damage and causes that. So I'll leave that at that point, that kind of thing there. What I wanted to talk to you about today was something I've come across recently, which is PMDD, or premenstrual dysphoria disorder. It's a severe form of PMS. It consists of a range of physical and emotional symptoms. Every month during the week or two before menses begins, and occurs during the luteal phase of the menstrual cycle, between ovulation and start of the menses. Sorry. The phase lasts about 2 weeks, but can be longer or shorter. Although it is a hormone-related disorder, an endocrine disorder, it's listed in the DSM-5, Diagnostic and Statistical Manual of Mental Disorders, and it's psychiatry's equivalent of the Bible. As PMDD has emotional symptoms, it is defined as a mental disorder and may be confused with depression or bipolar. It is not a hormonal imbalance as such, like PCOS and endometriosis. Symptoms of PMDD include every day or for a few days within the luteal phase. Mood swings, tearful, lethargic, hopelessness, suicidal feelings, anger, irritability, anxiety, pain in muscles and joints, headaches, feeling bloated, changes in appetite, overeating, food cravings, sleep problems, unlikely to experience symptoms during pregnancy, but the symptoms may return once ovulation begins. Diagnosing PMD. Your medic may ask you to keep a detailed record of your symptoms for approximately 2 to 3 months. Ask you about your medical history, your mental health problems. Ask about your lifestyle, smoking, alcohol, overweight, give you a physical examination and blood tests to rule out other medical problems. Getting a diagnosis may feel like a long process and frustrating, waiting for a long time to get treatment. Getting the diagnosis of PMDD can be difficult due to several factors. It may take a long time to consent to connect the correlation between symptoms following a regular cycle and linked to your monthly cycle. PMDD is not very well understood amongst health professionals, although 10% of women have it. It's distressing and frustrating if you feel health professionals are overlooking something or not taking you seriously. Measures you can try: keep your own diary. A detailed record of symptoms over these helps you explain your symptoms to your doctor. Take the PMDD guidelines to your doctor. Ask for a referral to mental health, endocrinology, gynecology, or an advocacy service. There are a number of treatments for it, mainly SSRIs, or selective serotonin inhibitors, are the only one that will work for PMDD, although they work differently compared to situations for depression and that kind of thing. I'm not going to go into all of that because it's really detailed and that kind of thing. What I would like to go on to now is something that's very close to me and my heart. I'm just trying to find my page. Yeah, I found it. This is reproduction and mental health services. I believe the state abdicated its responsibility to the church in the provision of, e.g., healthcare, education, and mother and baby homes. There was an overarching Catholic ethos in the mental health services. Contraception was often not prescribed, if permitted at all. Basically, because services, even though they were state run, would have maybe religious staff employed, or the selective Catholicism ethos of the protectionists was not considered, so it wasn't considered important or relevant if you weren't in an established relationship, particularly marriage. Single relationships, you were not encouraged, and still an issue even in recent times. The psychosocial disability takes preference in denying the right to fulfilling the essence of what it is to be a woman, and deemed incompetent and inept to the role of having a relationship, motherhood, and being a parent. Often encouraged not to have children, if at all, discussed due to factors including psychosocial disability, label, genetic links. It's rarely considered other physical features may have an impact on reproduction and the ability to conceive due to infertility issues, PCOS, or endometriosis. It's hard enough when faced with physical inadequacies around reproduction, pregnancy, motherhood, and the parenting role without making generalizations and assumptions about a woman and surmising, critically analyzing, making assertions, casting aspersions, and passing judgment on their personality and character traits and competency to fulfill the role of womanhood within the medical sphere, society, and by those close to them, and should ponder whether it's relevant and important to them, and should ask and consider their thoughts, emotions, feelings, and sensitivities, as it may not always be merely a lifestyle choice. So I'm going to finish there.
Thank you so much, Fiona. And I think really just that really clear articulation of that biopsychosocial, and we were all taught that. And whether you go to nursing school or med school or wherever, the whole person, biopsychosocial, and you've really clearly identified how that doesn't happen, and people give a label. And what was interesting, I thought, as well, was and the link to NEMS was like you have often no autonomy on the identity that's put on you. You have multiple identities, but the healthcare service or society in general chooses the one that they can have most control with you about, whether or not that's the one you need to interact with. So really interesting. So thank you so much for that and sharing your own personal experiences and as well, which is often quite difficult to do, but many people have done it, and it's really a privilege to listen to that. Our next speaker and our final speaker for this panel is Rebecca Opezia Alizzi, who is a PhD scholar currently at the University of Nottingham, where she also did her Master's in Public Administration. Prior to that, did her undergraduate at Tangaza University in Kenya. And her research focuses on women with disabilities and access to sexual and reproductive rights throughout the Kenyan healthcare system, and has done lots of different work in championing and advocating for women's rights and disabled women's rights across East Africa, and particularly through the Kenyan Organisation for Persons with Disabilities, both on an international and national stage, and has done some amazing work in founding a disability outreach program at Youth with a Mission in Tanzania, and also as a regional coordinator for the National Council of Persons with Disabilities. So really looking forward to hearing your paper, Rebecca.
Thank you. Thank you very much. And thank you for the introduction. I'm really happy and honored to be here today and to participate in this summer school. It's been my long time dream and something that I've been aspiring to. Yeah, as a woman with spina bifida, access to health is a topic that is very pertinent to me, and I'm really grateful that I've been chosen to participate in this panel. Yeah, just like it has been mentioned, I'm currently pursuing my PhD at the University of Nottingham, and I'm focusing on the lived experience of women with disabilities, access to sexual and reproductive health in Kenya. Yeah, my study is mainly divided into 3 spheres. Yeah, the first sphere mainly aims at exploring the conceptualization of disability in Kenya and its influence on women with disabilities' lived experience of access to sexual and reproductive health. The second aspect explores the lived experience of women with disabilities' rights to access sexual and reproductive health services, whereas the last aspect explores how the Kenyan healthcare system influences women with disabilities' access to sexual and reproductive health services in Kenya. Yeah, to give you a context into my study, I'll briefly give you an overview of our Kenyan healthcare system. Yeah, so the Kenyan healthcare system is divided into 2. We do have the public and the private. The public is mainly dominated by the Ministry of Health and the parastatals. Yeah, the Ministry of Health and parastatals, whereas the private includes both for-profit and non-profit. The Ministry of Health ensures the functioning of the health system in Kenya. However, 52% of the entire health system in Kenya is provided by the private service. The healthcare system in Kenya is organized in a 6-level hierarchical pyramid that is level 1 to level 6. Level 1 to level 6. The best care is provided at the highest, which is level 6, whereas the lowest of the care is at the lower level, level 1. Majority of the public health facilities are at the lower tier. Yeah, so I'll go into my methodology. Yeah, to explore the lived experience of women with disabilities, utilizing the interpretive phenomenological approach. And with this approach, I'm aiming to capture the lived experience of women with disabilities and to produce first-hand account narratives. I've been able to utilize in-depth interviews to engage the women with disabilities. I'm targeting 20 participants, but so far I've engaged 14 participants, 12 women with diverse disabilities, and 2 leaders from the organizations of people with disabilities. Yeah, like so far, I'm yet to analyze my data critically. However, I've transcribed and I'm happy to give you a preliminary. I'm happy to give you a preliminary. Yeah, I'm happy to give you a preliminary findings from my data. Yeah, it is estimated that in Kenya, in every five women in Kenya, 1 woman has a disability. Women with disabilities are disproportionately disadvantaged compared to their counterparts without disabilities. The difference is mainly exhibited in income, employment, education, and access to health. Most of the women with disability live in rural Kenya, and they are non-homogeneous. They have non-homogeneous qualities, and that means they tend to experience a multifaceted form of discrimination. Yeah, in relation to the first objective of my study that aims at in relation to the first objective of my study that aims at looking at the conceptualization of disability in Kenya, several issues are coming up from the data. And in terms of the conceptualization of disability, you'll find that communities attribute disabilities to the situation of people with disabilities. So they attributed it to themselves, to others, and to the will of God. These conceptualizations of disabilities, through the conceptualizations of disabilities in Kenya, people tend to tag or to consider women with disabilities as asexual. In my data, or through my interaction with women with disabilities, I found out that women with disabilities are sexual beings and they are sexuals. However, on the other side, the community thinks that they are asexual. And the conceptualization of disabilities and the sexuality of women with disabilities tend to subject women with disabilities to vulnerability. You'll find that, and to vulnerability, sexual abuse, and violations. In some cases, this is intentional, and sometimes it's due to social pressure. For example, sorry. For example, when I engage one of my participants, a woman with epilepsy, she told me that anytime she has an epileptic attack and she's not in control of a situation, that's when people tend to sexually abuse her with the claim that when they sexually abuse her, she will get better or she will get out of that situation. So there are a lot of misconceptions and misunderstanding surrounding women with disabilities sexuality, which renders them into vulnerabilities. This situation tend to make women with disabilities to feel dehumanized. Yeah, in line with my second objective, the Kenyan health system, while interacting with women with disabilities in Kenya, I realized that 80% of the women with disabilities, they were not aware of the services provided in the Kenyan health system. For example, in Kenya, we do have the National Hospital Insurance Fund, and this is a program or an initiative that facilitates access to universal health coverage. And most people in Kenya tend to access services through the NHIF. But on the other side, most of my participants were not aware of the services or how to access the services through the initiatives. Yeah, women with disabilities are often not included in policy formulations. Yeah, policies are not candid on the needs and the rights of women with disabilities, and that makes it hard for the implementers to target them. Yeah, something else that really came out from my data is that women with disabilities hardly find services in the public hospitals. Yeah, like mainly, ideally, the access to sexual and reproductive health services should be free in the public health facilities. However, when women with disabilities try to access them through the public health facilities, they tend to find that there are no services there, whereas in the private, it might be too expensive for them to afford it. There's also been the issue of healthcare workers' insensitivities towards women with disabilities. And this has mainly been through them asking questions that are ableistic or insensitive. Most of them, they told me that they were asked, who raped you? Even you, how could you get pregnant? And how could you get yourself into this situation? And these are statements or sentiments that tend to dehumanize women with disabilities. Yeah, they tend to dehumanize women with disabilities. Yeah, in line with my third objective, the lived experience of women with disabilities, we find that because of the barriers and the consistent discrimination that they tend to experience, women with disabilities tend to find themselves in life-threatening situations. Yeah, for example, when I engaged one woman with cerebral palsy, she was able to tell me that she was in labor, but when she went to the hospital, they told her that they don't cater services to people like her. So she had to hop from one hospital to another, yet she was in labor and due for delivery. So this is a situation that can put the life of women with disabilities at a risk. Yeah, and I've seen a situation whereby through my engagement with women with disabilities, I've seen a situation whereby women with disabilities try or they forgo the services. Yeah, like most of them, they've been to the hospitals and they encounter very harsh situation or very difficult circumstances through the healthcare negative attitudes, through the community's response to their sexuality. Most of them have spoken about giving up on accessing sexual and reproductive health. Yeah, just like it was presented yesterday, denial of reproductive autonomy is something that has come up from my data. This is mainly through being denied the right and chance to access services. For example, I interacted with a woman with spina bifida who really wanted to have a baby through cesarean section, but she was told she cannot do it because she's capable and she should not think of having a cesarean section. So there's one aspect whereby women with disabilities are subjected into forced sterilization and forced abortion. But on the other side, there's an aspect of being coerced or being prevented into accessing the service when they really need it. Yeah, another aspect that has come up, has emerged from my data is the burden of single parenthood. Due to the circumstances surrounding women with disabilities, like the sexual abuse and being viewed as asexual, most of them have ended up having, most of them end up having children, but having being in a situation whereby they are the mom and the dad, if I can say so, to their children. The last thing that I've encountered in my data is ableism. And its contradiction. For example, I see like our community sees women with disabilities as being asexual and people who cannot engage in sexual activity or have children. But on the other hand, I can see women with disabilities having children and and having their sexual life just like any other human being. So I'm seeing a lot of ableistic attitudes and a lot of contradiction around that area. Yeah, thank you so much for giving me the audience, and I'm looking forward to responding to any questions. Thank you.